good to see a house full of radiation oncologists, because since last 2 days I was just so within medical oncology and surgical oncology field, and it's very nice to see Dr. Shivasa and Dr. Sumit Basu also. So half of my work has been done so by Dr. Moses, and I would like to thank him for that, because I will not have to make so much of a presentation here. So as we have learned about the OAR doses and the target delineation and the motion management, and so what are the doses that we need to deliver for lung SBRT depending on the location. I would like to say that for the plan evaluation in SBRT, there are some factors that we need to consider before we start the plan evaluation. So first one is the total dose. What is the total dose that you want to deliver in lung SBRT? What is the dose per fraction that you have chosen for the total dose, and the number of fraction that you are going to deliver, as well as the calculation algorithm in your treatment planning system. So that is also important, because it will have an impact on the local control as well as your dose coverage, and especially the number of beams or arc angle. If you are planning for IMRT or 3D CRT or the VMAT, then you need to consider the number of beams and the arc angle also. So first thing is I'll come directly to the point and not Matabush around here. Plan evaluation for the coverage. So for the target coverage parameter, we need to consider the V95 of the prescription dose, V99, and the D max as already elucidated. High dose spillage and the intermediate dose spillage, that the R50 and D2 centimeter, and the critical organ at risk doses. Here the critical organs, as already been mentioned, is the lung, the cord, the esophagus, the bronchus, the chest wall, or the brachial plexus. Now, so when we want to evaluate the plan, there are two methods to do that. One is the slice by slice dose evaluation, and the other is the dose volumetric histogram analysis. So, so when you are treating the lung SBRT, it is preferable to do both of them. So one by one. So first one is the slice by slice dose evaluation, and also by the deviation analysis. It is not going to take so much of a time, because we are treating a smaller tumor less than 5 centimeters, so hardly there will be 15 to 20 slices. We need to have a good look at each axial slice, because there might be dose compromise at the craniocaudal target. And if we go by the RTOG 0236, so because the radiation therapy oncology group was the first one to do the prospective study in the lung SBRT, what they have defined in their first paper, or in the first protocol, that the prescription isodose surface should be chosen such that 95% of the target volume is conformally covered by the prescription isodose surface. For example, RTOG 0236 has delivered 20 gray in 3 fraction to a total dose of the 60 gray for T1 tumors, and for T2 they have delivered 22 gray into 3 fraction. So V 100% of the prescription dose should be the 95%. So that means the 60 gray iso dose should be covered by the 95% of the target volume. And then 99% of the PTV should receive a minimum of 90% of the prescription dose. That means your target volume, that the PTV, 99% of the target volume should be covering a 90% of the prescription dose. So that is the 54 gray. So these two parameters, if we go by the RTOG 0236, should be achieved. And the ISO dose should be chosen by more than 60% but less than 90%. So this was the ISO dose-based prescription. We are choosing the prescription ISO dose surface to be covered by the PTV volume. Now, so this is the dose volume histogram analysis. As you can see here, the 60 gray is being covered by the 95% of the prescription volume. So target volume is 95%, and you are covering the 60 gray for that. And this is the 19% of the prescription isodose, that is the 54 gray, and it is being covered by 100% of the volume, and it should be covered by more than 99%. So we are achieving particular the criteria set up by the RTOG 0236. Now, what do you mean by high dose spillage? High dose spillage, there are 2 or 3 criteria for that. Any dose of more than 105% of the prescription dose. So for example, 21 gray per fraction. So that means the 63 gray in 3 fraction should be within the PTV. It should not go beyond the PTV. It should remain inside the PTV and not go beyond the PTV. So we need to take into that also in consideration. And the conformity, we have heard Dr. Tanvi Shahid's presentation in the morning. The conformity, there are various methods to do that, but here in the RTOG 0236, they have defined that the ratio of the volume of the prescription isodose to the volume of the PTV should be ideally less than 1.2. That means if your prescription isodose is of the 60 gray, then it should, and divided by the volume of the PTV, should be ideally less than 1.2. For example, Here the PTV volume is approximately 30 cc and your V100 is 34 cc. So if you divide by 34 divided by 30, it should be, and here it is coming out to be 1.1. So we are okay with that. It is less than 1.2. Now, so what is the volume should be when it is going outside the PTV? Yeah, it will not be there that there will be no dose outside the PTV. There can be some dose outside the PTV of the prescription acidose. So any volume, so that is going outside the PTV receiving more than 105% of the prescription dose should be less than 15% of the PTV volume. Here, for example, the PTV volume is same as that of the 30 cc and the 15% of 30 cc is 4.5 cc. So our volume of 105% of the prescription dose, that is the 63 gray, is only 2.4 cc. So 2.4 cc is less than 4.5 cc. So it is also reaching our objective of more than 105% of the prescription dose should be less than 15% of your PTV volume. Now coming to the low dose spillage in the lung SBRT, there are two methods to do that. First one is the location and the second one is the volume. When we talk about the location, we have to draw a 2 centimeter shell around the PTV. So that is the D2 centimeter. So it is the maximum total dose to any point 2 centimeter or greater away from PTV in any direction, be it the lung parenchyma, be it the chest wall, or be it the mediastinum, any direction. So for example, here the 28 gray ISO dose is covering the PTV of 2 centimeter. So this is the 28 gray here, the D2 centimeter. So what about the volume? The volume is given by R 50%. R 50% is defined by the ratio of the volume of the 50% of the prescribed dose. That means the 30 gray volume dose to the PTV volume. Here PTV is of the 30 cc, and for example, if the V50% volume is 110 cc, then the R and then the ratio of this would come to be 3.6. So where are these values have been written? So RTOG 0236 has given this value. Here the V20 is also less than 10%. I'll see to that. So this is the table that has been provided by the RTOG 0236. Here the ratio of the 30 gray, that is the R30 gray, is the R50. So minor deviation is 3.9 to 4.1 is the ratio, and the maximum dose is approximately 28.1. So this has been both given so by the maximum PTV dimension as far as the tumor size is concerned on the left hand side, as well as the volume of the PTV. So these are the OAR dose constant that has been given by RTOG 0236. That was the 20 gray in 3 fraction, and RTOG 0915, which was a randomized control trial between 12 gray into 4 fraction versus 34 gray in single fraction. So this is the right hand side is the RTOG 0915. You do not need to remember all of this table. You can just take the snapshot of on your mobile and please check. So whenever you are evaluating the RTOG or the lung SBRT plan. But there was a fallacy in the RTOG 0236. So because it was started in the year of 2002, so many of the treatment planning system and the institute did not have the tissue heterogeneity correction in the treatment planning system or in the dose calculation algorithm. So when they retracted the plan from different institute whom they did not have the tissue heterogeneity correction and they applied the tissue heterogeneity correction, you can see the red line, the inside line is of the 100% prescription acidose, and the dashed line is the PTV 2 centimeter, and the solid green line is the 50% acidose. So if you apply the heterogeneity correction, the 100% prescription acidose do contract and the 50% acidose expand due to the lung tissue heterogeneity. And what they have concluded that with heterogeneity correction applied, the volume of PTV receiving 60 gray or more was on an average, they decreased by 10% from 95%. So here they have taken the largest tumor size example. Here they have shown that the PTV was decreasing. Sorry. So here they have shown, if you can see my arrow here, here the volume of the 60 gray was covered by the 95% of the planning target volume. But here, if you apply for the tissue heterogeneity correction, it was only being covered by the 60% of the planning target volume. So the tissue heterogeneity correction is very much important in lung SBRT. So they revised their table. If you can remember, so this is the volume on the right hand side and the left hand side is the tumor size. Now, if you compare this, so for the 1.8 PTV volume in CC, previously the minor deviation was only 3.9 to 4.1. So anything which is more than 4.1 will be considered as the major deviation. But in an updated table, so because the R50 will expand, so they have revised their ratio up to 7. Okay, so this has changed from 4.1 to 7 because of the lung tissue heterogeneity correction. So this is the importance of dose calculation algorithm that you need to take into account. Now, so this is the prime example of the comparison between the equivalent path length versus the Monte Carlo system. Here you can see that if you use the equivalent path length, you are overestimating the dose that is being delivered in the lung. But in reality, if you calculate by Monte Carlo, it is actually lesser in lung tissue, and it is much more when you have, so when you are calculating at the edge of the PTV. If you see the center, that is the A type, here the equivalent path length is slightly overestimating the dose, but at the border of the PTV, because there is a tissue heterogeneity at the border of the PTV, the difference so between the reality and the overestimation by the equivalent path length is much more larger. Now, the dose calculation algorithm also impacts the local control. Has already been mentioned by Dr. Moses that we need to achieve a BED of 100 gray, but there are reports that the BED, if it is more than 130 or 150 gray, the local control can be more, so much more better. Now, it does not mean that we should not achieve the 100 gray, but if you are achieving the 90 or 96 gray, the local control will also be good, but we need to achieve a BED of 100 gray at least to have a good local control rate. Now, this is the RTOG 0813. So this is for the centrally located lung Sbrt patient. Here, the ratio of 50% prescription isodose volume has slightly increased from 7.1 to 7.5 for the same tumor volume. So you do not need to remember all of this. You can just refer whenever you are doing a lung Sbrt plan evaluation. So this is the dose constant that they have given for the central lung Sbrt, because for many of the times, if you are treating a central lung Sbrt, there will be organ at risk, so which are very close in contact with your planning target volume. So for the organ at risk, they have said that no hotspots should be within that organ. And if it is going, even if that organ is a part of the PTV, then OAR should receive more, no part of the OAR should receive more than 105% of the prescription dose. And they have given for the spinal cord, ipsilateral, brachial plexus, lung, esophagus, heart and pericardium, all the dose per fraction and the maximum dose that should be achieved, or it should be less than that, that you can consider this table. Now there is, so there is a concept of the ultracentral tumor, because if you are going to do so, because in RTOG 0236, which was published afterward in the year of 2014, so before that, Timmerman et al. Has already said that there is a no-fly zone, that the proximal bronchial tree and 2 centimeters around it. But so with time, we have changed our dose per fractionation for the central and the ultracentral tumor. Here you can say that the ultracentral tumor are any tumors where your IGTV or ITV is either overlapping or abutting the critical OAR structure. So this is a sunset study which is being ongoing in Canada. They are evaluating the dose per fraction. It's a dose escalation study from 5 gray to upward of 5.5 to 6 or the 6.5. So here are the dose constraints. So this is an example of ultracentral lung Sbrt where your PTV is directly touching the right main bronchus. Now, these are the two ISO-dose based prescription. First one is the ISO Center, which is commonly practiced in the Japan. It is a homogeneous dose prescription, and ISO-dose based prescription, which is commonly used by the RTOG to improve the dose fall off and increase the dose heterogeneity inside the target. Now, this is an ongoing Japanese trial because they have used 48 gray in 4 fraction, and the current experimental arm is the 55 gray in 4 fraction for the dose escalation. So I will conclude that the careful plan evaluation in lung Sbrt is very essential, because there are obviously critical structure, and this patient already have a poor pulmonary compromise. Smaller miss can cause greater harm to the patient. So we need to be very, very careful and look at each slice in all the 3 planes, like the axial, coronal, and the sagittal, and the risk adapted strategy based on the tumor location will help us in not doing a greater harm to the patient.
Thank you, Dr. Anil, for presenting and concluding well within time. And as